So coronary anatomy, we all know that we have three main arteries that we deal with. So left main, I think very important both clinically as well as technically to know where left main arises and the size and length of the left main. That's about, I would say, 0 to 10. Why I say 0? Many times there's no left main and there's a separate origin of LAD and circumflex. So when LAD arises separate, if you can see there, when LAD arises, it is separate, you'll come out. So this is the left main length, but if LAD is coming, it will be coming out, it will be, circ will be down and out, and LAD will be anterior takeoff, okay? This is for you to know if it's a separate origin. When you are engaging the catheter, you take JL40 and then you are going into the LAD, and what will you do to get into the circumflex? Okay, so counter always takes you anterior. Counter will take you anterior and higher. So you have to clock to go inferior and circumflex. So you have to do this movement. If not, JL is going right into the LAD. So if you want to get into the circumflex, which is down, okay, which is further down and lower, you need a larger catheter. So you have to remember this so that you know when you're engaged and there's no left main or there's a short left main, the catheter is just going into the LAD, you're only seeing LAD, you pull back and clock to get into the circ and take a picture. That's how you see it. Okay, you need to know this, otherwise you'll be just twirling, don't know what catheter size you're going to ask. Suppose you take JL40 and you go, when you engage, you just go into the circ, then you counter to get into the LAD. And if it still does not get into the LAD, you have to call the tech to say you want a shorter catheter to go get into the LAD. So very clear. These questions will come over and over for catheter selection when you're doing during the anatomy there. So same thing I mentioned. Judkins is a very common catheter, everybody knows, for the left, and other important catheters, you know, Amplats, XBU, all these catheters are there. So if it's separate origin, and that's what I meant, circumflex is always down, out, larger catheter. Remember that. And a counter clock for LAD, clock for circumflex. What is the optimal view? Because they do ask this question in the boards. Optimal view for LAD. If they tell you one view, okay, epicranial will tell you the proximal to mid. If you want to see mid to distal, RAO, okay, straight RAO, two views. And if you know, high creatinine, you want to take one, you go to epicaudal, you see everything, okay, left main, ostium, distal, LAD, all the way down to the. So if you see here, LAD comes down, out, all the way to the apex. And when you come here, you see this mustache. Okay, then you know that's LAD. Many times you don't see mustache, doesn't matter. If the dominant the dominant RCA, you will see the PDA coming interventricular septum, come all the way to the apex, and then you can see the mustache. That means it's a dominant. So how it's separated, you see that? You have right ventricle, left ventricle, interventricular septum. Okay, so what runs on the surface on the top interventricular septum is LAD, and right coronary artery goes this way, wraps around in the AV groove, and the PDA comes into the interventricular septum. That is why in the RA view you see LAD on the top and RC in the bottom. And why you need this view? If you're going to become a CTO operator, right? So if you're doing anti-retrograde approach, you need to see the septal to septal collaterals, so that you can see only in certain views, which is RAO, maybe epicranial. So that's why you need to know how the anatomy of the vessels. So you have to exactly understand when and at all you're going to do the CTO procedure. And very important, when you're doing an angiogram and if you see RCA is occluded, right? When you're doing and you see RCA occluded, which is the best way to see the RCA occlusion from the left system? Aleocranial. When you do aleocranial, you will see the RCA that's occluded but fills from the collateral septal of the LAD or apical LAD. Exactly what I showed you. RCA coming all the way down, interventricular septum. So this is the crux. Crux is a very important. Why? Interatrial septum meets interventricular septum is the crux where PDA and AV continuation separates. PDA is a dominant vessel which will tell you which is a dominance, and they can ask you that question also. So right dominance about 95%, 90%, then another 10% is about left dominant, some will be co-dominant. That's the way you can consider it. So other thing that you need to know also is, this is the crux I showed you here, all this AV continuation and all the RPLs in the RCA. Anterior descending, you see, going all the way down, and very important, it supplies a lot of the myocardium. That's why if you have proximal LAD occlusion, likely if you have not opened the vessel immediately, they go into cardiogenic shock. 40 to 45% of the left ventricle is supplied by the LAD. And going back to the picture of the LAD, let me see if I have in the future. Okay, here is, what are the branches, right? LAD comes all the way down. So into the interventricular septum is septal, lateral are the diagonals. And the circumflex will be what? How do you also define LAD? From the origin up to the first septal is proximal, first septal to the, in the RAO view where you see the LAD going down and out will be mid LAD, and after that will be the distal LAD. And these things are important. They may ask you how you differentiate. Left circumflex, okay, goes down and out. Very important also, this they can ask this question. SA nodal artery often arises from, the most common is from the right coronary artery. They can ask this exact number. So you can remember 60-40. 60% from the right coronary artery and 40% from the left, which is the circumflex. And what are the branches is obtuse marginal. So circumflex definition is prox circ up to the origin of the obtuse marginal. After that is all distal circ. Okay, and depending on if the PDA is coming from the left, it's called left dominant, otherwise right dominant. About 40% of the muscle is supplied. And right coronary we have gone through. Now, there's another question they like to ask is what are the branches of the right coronary artery? Okay, so the first branch that comes off the right coronary artery is the conus. The conus arises about 10% separate origin of the RC. And why it is important is, suppose you have an LAD that's totally occluded. You say mid to LAD totally occluded. We do LV function is normal. This question is often asked. Then when you go to the right coronary artery, you don't see the LAD. Why? The conus, okay, the conus, which is a separate origin, is filling the LAD via the septal collateral. That's called the circle of Vuissens. They can show you the picture of the circle of Vuissens that's filling the LAD. So if you have a normal LV function, you don't see the LAD, do a non-selective shot in the right sinus. You can always see the collateral. That is why you have to know the branches. So first one is a conus, second is the sinoatrial node. In the sinoatrial node is same, 60% of the sinus artery comes from there. The rest is all the atrial. Then the first branch after that is the RV branch. And RV branch is important for us if they present with the RCAMI. So if you have RCAMI, I mean usually now nobody does left-sided and the right-sided lead to see exactly if there is a RV involvement or no, because the goal is to rush the patient. But very important, you have to know if there is RV involvement, you cannot give. That's your board questions for cardiology. No giving nitro, just fluid. But that's the things you need to know. And then it comes all the way down, acute marginal, and then you have PDA, AV continuation, and the RPL branches. It's the same thing that we are showing. Optimal views, often the question comes. So if it's AP caudal, right? Straight AP caudal, what do you see the best? Is left main, prox LAD, right? And distal LAD you are able to see. Then AP cranial. Always remember, cranial is always for LAD, caudal is always for the circumflex when you are doing the left side. Okay. So in the cranial view, what will you see? LAD, diagonals. And distal circumflex, if you're seeing LPL, LPDA, you can see in the cranial view. And same thing in the aleocranial. Aleocranial, like I mentioned earlier also, you'll be able to see if the RCA is totally occluded. And aleocaudal, right, is circumflex, proximal left main, proximal LAD, proximal circumflex. That's the view you want to use if you're doing left main intervention, distal LAD. What is the best view for ostial left main? Straight AP cranial, aleocranial, because in the you have to see cranial view, not for the distal. So many people confuse aleocaudal. Okay, aleocaudal is always for the left main. I know, I think we have to make it distal left main. Ostial left main, cranial view if you're stenting. Why these views are important for intervention is not just angiogram, understanding whether there is a any stenosis. Important also when you're stenting, okay, which view you want to use when you want to nail the ostium. So cranial view for the ostium of the thing. So these are some questions that we will go over now. Mid to distal LAD, AP areocranial, right, diagonals, distal OM, LPL segment. Now, why AP? I always, very important for you guys also. AP areocranial, LPL. If there's a lesion in the LPL, don't go RAO or areocaudal. You're not able to understand the length that you want to actually stent. Has to be straight AP, a little bit cranial view, and distal RCA bifurcation. Again with the same AP caudal, areocaudal will be prox LAD, prox circumflex, and if it's a short left main. Now question 1. This is match the following. Start telling me. LAO 60, caudal, aleocaudal. Which one? Areocranial, A, right? Then areocaudal, and then aleocranial, mid to distal RCA bifurcation, B, right? 1 is C, 2 we said is A, 4 was what? B. Good. They will not give you questions like this. It is just we created questions so that you understand, okay? They'll give you a case history and show some angiogram and then ask you some questions like that. So spider view, what is a spider view? Which one will you pick here? D or C? So no. D. Okay, that's caudal view. Okay, this I have explained. If there is a left main is absent, LAD is more anterior. Yes? Everything except LAD has anterior takeoff. Which is wrong? LAD you go counter or clock? So that is correct. Is a larger catheter required for LAD or circumflex? So which one is wrong? Severe stenosis, anomalous circumflex. Anomalous circumflex actually also comes in your cardiology board exam. They can show you an LV gram with a button sign. You know that, right? If the anomalous circumflex, which is a common anomaly, there's what is called as anatomical variant and a coronary anomaly. So left main absent, left main is a anatomical variant, okay, it's not an anomaly, but the commonest anomaly is left circumflex coming from the right side, and then what does it do? It goes posterior, okay. That is why you see the button sign. When in the RAO view, when you're doing LV gram, it goes posterior. That's the usual course, so that it's easier go posterior and reach the back of the heart. what is the commonest catheter? So how will you know? So it's either coming from the RCA or it has a separate origin, right? If it's coming from the RCA, is easy. Usually your Judkins catheter gets into the RCA and you will see the circumflex. If it is a separate origin, which would be the best catheter? Multipurpose of the choice. If it's not, they're given AR also. AR1 usually, because you want a short AR, which is AR1. AR2 if it is anterior takeoff of the right coronary artery. Okay, everybody understood this? Anomalous origin of the circumflex, very common. So remember that, which will be AR1, if not multipurpose, because it could be takeoff down, but AR1 is the catheter of choice, because you could have to do intervention in the circumflex that you're seeing here. Which of the following statement PCI of the LAD is true? If the ostium of the left vein is high or aortic root is small, once in the left vein, gentle clockwise goes anterior. So which is the correct one then? F. Only B, A and B are true, right? The rest are not. So clock takes you posterior, and if you have a small root, you're not going to go with a larger catheter, right? Left circumflex applies. Okay, this should be a straightforward, straight shot. See, RCA 60, remember that? Okay, they could ask the other way around also. Okay, I mentioned what was the artery I mentioned to you guys? I did not mention this artery, circle of Vucens. So that is from the sinoatrial sinus branch. Yeah, septal is a circle. Kugel's artery, anybody knows? Okay. So now sinoatrial, right? So the atrial part connects to the AV nodal branch. AV nodal branch usually comes from the AV continuation. So that connection is right to right collateral. So many times, if you have that collateral and you have a toe mid or RC occluded, you may not want dual injection, but you just have to be careful because you have right to right collaterals that's filling. That is important. Also that is why right coronary artery, when right RCA is occluded, you have so many arrhythmic events during RCMI. You have sinus node that is occluded, AV node branch that is ischemic. So that is why you go into all kind of arrhythmias and heart blocks. Okay, that's good. Okay, this is the button sign I was talking about. You see it? This comes in cardiology board, can come here. They can give you a picture like this, or they can show angiograms, videos. Okay, where when you see it, you'll see the circumflex going behind. So remember that. And of course, what they'll do is they can change the question. They can give you any kind of questions. Somebody presenting with chest pain, MI, then they're trying to engage, they cannot find the artery, then they show this angiogram, either what it is, what kind of catheter will you use, what would you normally see, do a different kind of an EKG to understand if it's posterior MI. So, question can vary, but essentially they're trying to say if you know that the circumflex is originating and going behind. So you see that. So what is here the question? What's the answer? Origin of the left from right. Now a lot of questions will come with the FFR, CFR, IMR, the new devices which yesterday we were discussing about IMR, but that may not come because it's very recent, but definitely FFR and CFR. So FFR always is what? Yeah, no, I know it's fraction flow reserve, but it's a stenosis in the epicardial artery, right? That's what you need to know. And CFR is microvascular. Okay, now further they have divided a lot of things that hopefully will come later. So FFR is here, PD, PA. You see that? This is what you need to know. And what is the usual FFR number? Point? Yeah. Then anything less than that is significant, right? and I don't know whether they'll ask you specific questions, how you do an FFR. I don't know if most people probably have done FFR by now, right? So you have to leave it a few millimeters further down, wait, then start the adenosine, do a nice pullback, all these things they will ask. So make sure you learn the technique if they may ask you any questions related to that. But number wise, you have to know that. What is the number for CFR? So fraction flow reserve is what? Ratio of the distal coronary flow and aortic pressure in the presence of stenosis, maximal hyperemia. And usually they say it's independent of the driving pressure, which is heart rate and systolic blood pressure. So normal value is 1. So remember that. 0.80 is abnormal. Actually is not less than or equal to. 0.80, 0.79, any of those numbers. CFR, just remember the number. What's the normal CFR? Anything? Yeah, normal is more than 2.5, less than 2.5. 2.5 and less than 2.5 is abnormal. What they normally can give you is that, to make sure that it is dependent or not, they'll make some history on a patient, somebody with hypertension, those kind of things. So these are the numbers you need to know. Now, they can also ask you questions related to FFR trials. So you have to, I think Dr. Sharma is going to go over most of the trial questions. So remember that, okay? DEFER and other trials, they will ask you what was the number in each trial. They like to sometimes give a question and then put the trial responsible for which change the guidelines, okay? So now 60-year-old male, 6 weeks of transmural inferior wall MI and having akinesis of the inferior wall segment on echocardiogram has 85% residual stenosis. FFR 88, CFR 1.2. Why is CFR abnormal? Because of the recent MI and microvascular plugging. So what are we supposed to do? Is stenosis functionally significant? Which could be the right answer, C or D? Because it's falsely positive because of a microvascular plugging. So if you have ostial RCA, ostial left main, which would be the test to signify, understand if this lesion is significant or no? If you guys have in the cath lab, what common? It's always important you try to do a physiological testing, okay? In the other anatomical testing, which includes IVUS, OCT, is more to understand plaque. Once you decided you're going to do intervention and then you want to decide on technique, that's what. But if you want to decide, should I intervene or no, always go for a physiological testing, whether it is FFR, IFR, okay? Not a CFR, so is FFR. What's the answer? So here, this is what I was saying. So significant threshold defined by FAME was 0.80. Okay, so you have to remember all the FAME trials. The initial was, DEFER was 0.75. So anything less than that was significant. Then they were unlikely to ask DEFER because nobody talks about it anymore. Everybody talks only about the FAME trial. Now, most people are, you have seen imaging, intravascular ultrasound, right? In your practice, everybody has done some kind of imaging. They usually show this kind of pictures, or they do show a run of IVUS, okay? So you need to understand 3 layers, how to identify. See this intima, then you see like a black, that is media, and then the adventitia, okay? But this is how a normal coronary artery is supposed to look like. So this is soft plaque, right? Now, if you see calcium, C is calcium, you don't see any ultrasound going behind. So that you know is calcium. You see that? And then how do you define calcium? Mild, moderate, severe, based on the quadrant. So you divide into quadrants, right? Anything more than 1, 2, 3 quadrant, yeah, will be severe. So anything more about 1 or so is mild, 1 to 2 is moderate. So that's how you do. So 360-degree arc of calcium is severe calcium. That's when yesterday all the discussion was happening. What's the kind of treatment you need to do? Those kind of questions, they may just show you this and then ask you different kind of devices that you want to use. Now, once you see what calcium is, then you know to differentiate what fibrous plaque is. So you see that it's not, you can see behind, but it is, you can see clearly this is fibrous tissue, okay, compared to the calcium there. That's a big difference, and this is how you see this plaque. Now, if you want to differentiate if it's wire or if it's plaque, what do you do? You have to understand, right? How do I get the MSA of plaque? Do live. That time you see if it is moving, blood is moving, you know it is not plaque. So very important. Don't make it look like, you can freeze it in a frame to make it look like a plaque, and then calculate wrong MSA. So you have to make sure that when you're calculating, you know exactly how you're calculating. So the other one is optical coherence tomography. Again, same thing, 3 layers. You are able to see the 3 layers, right? Same intima. Look at this nice media, adventitia. So this you are able to understand, morphology much better compared to the IVUS. But you have to know all this. We don't know which one they will ask. Okay, so this is how a fibrous tissue looks like. Nice bright fibroatheroma. This is lipid. This is how you learn how to calculate the cap. And if you have calcium, you see a nice border here. That's how you differentiate. All the way from here, you see that? Close to 360, 3 quadrants. They may not show this, but you have to know the difference. Do you know what is it on the top? Once upon a time, we used to use this bioabsorbable scaffold, huge, like bricks. But this is how the normal stent will look like, okay, once you stent it. You see the difference? Yeah? These questions will come. What's the difference between OCT and IVUS? Anybody knows? This is what it is. 10 to 15 micron, yeah. And then frame rate. See, this is why I think you have seen I don't think we showed you the OCT live. You only saw it later. If you have done OCT in your lab, you've seen it's very fast, right? It just takes a couple of seconds because 180 frames per second, whereas IVUS goes 0.5 to 1 millimeter, very slow. Pullback speed is also faster. But what you are able to see is tissue penetration is very important. They can ask you this question. That is why, see, the IVUS tissue penetration is larger. That is why you can understand the plaque morphology. Tissue penetration is lower, but then the resolution is better. That is why you are able to see the OCT pictures much better compared to the IVUS. So this is what you need. So tissue penetration is less, more, but visualization is better with the OCT. So you have to know the difference. Now, blood clearing is not required. That is why OCT, you need to have what looks like a normal creatinine, because you give a lot of dye, so blood has to completely clear, so you're able to just see the picture the way we see it. And IVUS, we don't need any of those things. So they may ask you questions on the patient with creatinine clearance, and then which kind of imaging modality you want to pick. Then for you to know that you know the basics of both OCT or IVUS. Okay. So strength versus see good resolution. Like I showed you, high speed of pullback. Tissue penetration is better because of the depth, okay, that it can go. So fibrous cap, if you need to really understand the fibrous cap, OCT is better. Plaque composition, in both you can see it well. But if you need to understand vessel remodeling, plaque burden and all that, you definitely need IVUS because you need more penetration to see behind, okay? These are the recommendation. Essentially, the recommendations are that they haven't made it so much in USA, but you need imaging is for optimization, okay, not for decision. Like I told you, decision making, do any kind of pharmacological testing. So which of the following statement not recommended in the use of IVUS? D. You will not be able to see. I hope I have some pictures. Class 2A, okay? Which of the following combination of intravascular imaging is appropriate? 1, 2, I mean A, B or C? B, because OCT was 10 mark, right? Match OCT and IVUS. A goes with what? Yeah. C? C, B with A, IVUS, right? B with A, IVUS. And C with C? Yeah. So A with B, B with A, and C with C. So essentially it's fibrous plaque. B was a fibrocalcific. You see that, right? Calcium, calcium, and this is lipid, fibrous tissue there, fibroateroma. You keep looking at more and more pictures because they can show you. So essentially you have to know how you differentiate the two. Which of the following parameter not measured? D. You need OCT, right? Cap thickness you cannot. I mean, you can, but not the best. So we're done with this part. Now, before we start this, I want open for question answer session, guys. Preference for? No, we are talking femoral the catheters. Yeah, if you're going, it has to be JL40 and Judkins usual catheter. And I don't know if you have seen, but yesterday when we did the LV gram, we used the JR catheter to get into the LV. So we never use pigtail. And the so-called LV gram, we just do it with the hand with 2 cc's of the JR catheter, not like a proper pigtail and Medrad injection, 40 cc dye. Those things, I don't think anybody does it because you have a nice echo. You don't want to expose anybody to a lot of dye. Yeah. And I think if they were doing a radial, you can go with Tiger or JLJR, whatever the person's preference.
Along with this region on the left side, you mentioned MPA, will you also use AL1?
No. AL1 is too big. AL1 will be if you are if you have a left main. So I said commonest anomaly is the circumflex coming from the right side. What is the other anomaly that you see next is the left main that is coming from the right sinus. So we have a publication. We have a new handbook that has come out, Interventional Cardiology Handbook. Anybody knows about it? We published just a week ago. Springer has it. There we have mentioned of catheter selections for anomalous. Okay, there for the left. Suppose the left vein is coming from the right side. All depends where it is coming from. Yeah. So it could be coming from the right sinus, or it could be coming from the midline. You have aorta. You have aorta of the left sinus, right sinus. So if it is from the left main mid sinus, RCA coming from the left sinus. So if it is coming from the right sinus and little anterior, then AR2 is okay. It's clear? RCA, right sinus, but it's anterior takeoff, AR2. If it's in the midline, maybe AR2. If it is higher up in the midline or going to the left sinus, that's the time you have to decide, maybe you have to go to AL1. Okay? And if it's really coming from the closer to the left main, then you have to go to the left catheters, which is usually FL, VL3O, not the bigger catheters, because the left main could come, RCA could come a little above the left main or below the left main. Okay, we have a nice diagram in that book, so you have to follow that. But it's clear for now, right? AR2, so you go from the right to left. AR2, AL1, and left-sided guides. So let's go over some few questions that we have. That's it. Any other questions, guys? Guide selection is very important. Catheter guide selection. Otherwise, you're wasting time and dye and multiple exchanges. Multiple exchanges up and down, in and out will give rise to stroke to the patient.
Other mentioned, keeping Phil ask us more about engagement in post-catheter.
I mean, that I'm not sure, but it could be. You have an app for that. We have a paper and we have the app, right? But if you want to select one catheter, Akari would be the good one that you can use on both sides. But the goal is, what happens, remember, aorta is now filled with this new cage. Remember, and the cage is metal. So the nice vessel wall, which actually is pliable, now you have a metal wall that's rigid. The big, not the sapien, but if you're talking about the core valve, in that situation, you have to go with the smaller catheters. So if it is FL4, FL3, like that. So that, but what happened, why we said Akari, because the way the Akari is made is smaller, 1.5, can go into the right as well as the left easily. But we have to know is you have to see the animations that we have created, that you use the J wire, get into the, the cage first, then use the J wire to engage, to go through one of the diamonds and come out and then engage into the coronary artery. Okay, so you have to see that animation where we have clearly shown you how you have to engage. But yes, if they can ask you that, but we have go for smaller catheters, whatever catheter choice they're giving. But you understand the concept is the pliable aortic valve is replaced by the metal cage that is rigid. So you need a smaller catheter. Okay.